All right. The Center for Indigenous People Health and Nursing welcomes you as we begin our celebration of Native American Heritage Month. We deeply honor the knowledge, resilience, and leadership of Indigenous peoples of the past, present, and the future. It is in that spirit that I am so honored to introduce Nicolle Arthun, a Dene nurse midwife from the Navajo Nation, whose work has uplifted Indigenous families and transformed maternal health systems. For more than 18 years, Nicolle has provided rural care in rural hospitals and community birth settings across New Mexico and beyond, always centering her practice on respect, culture, and relationship. In 2015, she founded Changing Woman Initiative, a powerful Indigenous led organization dedicated to protecting cultural birth resiliency and restoring traditional practices that honor the sacredness of birth. Through her leadership, Nicolle ensures that future generations can experience birth in ways that honor their identity and community. She now leads Transcending Strategies, where she works to create systems change in maternal and reproductive health, develop leadership within communities, and influence policy to reform Native health. Nicolle is internationally recognized as a leading expert in Native American maternal health and is a powerful advocate for reproductive justice. Please join me in welcoming Nicolle Arthun as she shares her presentation, Beyond the Birth Room, Sustainability Through Relationship Building, Policy, and Politics. Welcome, Nicolle.
Thank you, Misty. Hello, everybody. Yat from Washington, D.C. It's very nice to be here and to talk about work that I've done in my career and how it's influenced health policy change. I'm really excited to talk about things that I care about, but probably you guys care about too. And next slide. So how I would describe myself is that my body of work builds community-led midwifery-rooted care systems that restore self-determination and healing for Indigenous families. And then I move what I've learned in community into policy and human rights advocacy work that I've done in my career. And through that, I've founded care models that are culturally grounded in crisis-ready ways like Change Room Initiative and some of the work I did in Standing Rock, as well as really focusing on building trust-based relationships, cultural safety, and basically making an effort to address some of the gaps in access to care. I would consider myself a relational architect of living systems. I have a history and I span a community of policy, health, and networks. I've designed pathways others can follow, aligning stakeholders across sectors, and I catalyze changes through different positionings of authority and different positionings in regards to my leadership. This same approach informs my policy work as I'm currently a Robert Wood Johnson Health Policy Fellow here in Washington, D.C., serving in Senator Ben Ray Lujan's office. In the last couple of years, I've also provided testimony before the U.S. and the UN bodies, where I work to advocate and advance sovereignty over workforce, data governance, Medicaid, maternal mortality, and Indigenous priorities to shape law, funding, and outcomes. I'm really invested in building sustainable relationships and accountability that are led through community. Next slide. So my hope today, as I talk about my work, is that how I've used my experience as a policy catalyst. I'm going to share lessons from my time in Standing Rock, definitely learning and lessons from building a nonprofit called Change Room Initiative, as well as advancing health policy through my work, but really centering relationships for as avenues for change. I hope as each of you are listening and thinking about your own work and your the impact that you want to make in your own community, just figuring out kind of the insights of like, you know, it's everything that we really care about and are passionate about really touches all the things in our lives, our families, our relationships, and the things that we invest in. And I'd be curious at the end of my presentation to just hear a little more from you all, like the work that you're doing and maybe things and how ways you feel like it can inform policy in your community or on the national level or in your state. Next slide. So how I see wisdom of birth, how I've used the wisdom from the birth room as an Indigenous midwife. I use this kind of dyad of my clinical experience, my policy experience, and my community experience. And I see Indigenous midwives as one of the key designers of healthcare systems. And not only are we in partnership with our communities as Indigenous midwives, we are systems thinkers who use holistic risk assessment and relational decision-making to address issues while maintaining accountability to our community. Basically, we understand our communities well, and that influences our design process, especially in health policy spaces as we are considered subject matter experts in birth and community and Indigenous knowledge. Next slide. Something I'm learning, and even though maybe all of you, whether you identify as Native American or Indigenous, our collective history can be a little ambiguous, meaning like we have a collective knowledge that we have treaties and there's land-based and there's understandings between the federal government, but it's not always entirely broken down in a way that we can remember. And also, as we describe some of our challenges, being able to understand like what gives us the political status of Native people. One in particular is our sovereignty. So basically that means federally recognized tribes have inherent sovereignty, meaning that we have the right to govern ourselves, we make our laws, we enforce those laws, and we manage those laws and resources. We also have a trust responsibility. So actually the government has a trust responsibility with us. So basically the US government has a legal obligation to protect tribal lands, resources, and well-being stemming from treaties, statuses, and historical obligations. We also have a really interesting tribal citizenship relationship. So we are Native Americans. We are citizens of our tribes, but we are also US citizens. Our tribal citizenship is a political affiliation determined by tribal government. So it's not race-based. And as I go through my presentation, you'll understand why I'm making this distinction. Federal recognition gives tribes the ability as federal government to hold these I'm sorry, only tribes recognized by the federal government hold this political status. So this recognition allows access to programs like services and legal protections through the Bureau of Indian Affairs and Indian Health Services. So if we're federally recognized tribes, but there's over 500 plus in our United States, those tribes have special circumstances with the government that allow us to have education, healthcare, and different services that are funded by the federal government. In regards to legal standing, tribal nations can enter into legal agreements with federal government and sue or be sued in certain legal matters. So like the political status shapes how laws apply on tribal lands. And lastly, it's really important to understand that there's a distinction from race-based classification. It's basically saying that there was a court case between Morton and Montgomery in 1974 that affirmed that laws affecting Native Americans can be based on political status as members of tribes, not racial classification. So the political status shapes tribal healthcare, education, justice systems, and relationships with state and federal governments, including how maternal health is governed and funded in tribal communities. Now, there's a lot of information. I think when I talk with community about our political status, I often make the distinction by saying American Indian versus Indigenous, because American Indian has political status and illegal statutes and illegal treaty obligations that the government has to tribes. And I use that language because, especially in this current political system, when there was debates happening over Medicaid and what kind of, how do I say, cutouts they would make for certain people, there was a challenge with viewing American Indians as a special interest group or racial organization or racially based group, rather than understanding that there's a political obligation to pay, and that we get to negotiate for different circumstances when it comes to our health and education. And so I use that language on purpose because I know it has a legal meaning behind it. Next slide. So in 2016, the Standing Rock tribe had led a protest against the Dakota Access Pipeline due to concerns about its impact on their water supply and sacred lands. This nationally coordinated resistance lasted about 6 months, with over 300 tribes and First Nations joining the movement in solidarity with Standing Rock. During that time, some of the tactics deployed by law enforcement were attack dogs, rubber bullets, water cannons, tear gas, and tasers. Like maybe you, and if you were around during that time, I was watching the things play out in Standing Rock from home, and it really moved me to basically do something and to act and respond. So what I did is I rallied a team of midwives to travel to Standing Rock to set up a field clinic. I had learned at the time that Standing Rock had been home, or the 3 camps that were there, half of the participants who were there were women and children. And so I was really wondering about kind of what kind of healthcare that they were receiving. And also being in North Dakota, they have kind of different laws when it comes to women's health and midwifery care. And so over a period of a couple of months, I mobilized the team and we traveled to Standing Rock and we set up basically a space. This is a photo of the yurt that we purchased. So just a little information about Standing Rock. It's the 5th largest reservation in the US. It comprised of Lakota and Dakota people. The field clinic that I established was in 2026. I'm sorry. That's like now, isn't it? 2016. So the goal was to create a culturally safe maternal and reproductive healthcare space at the front lines. As I mentioned, half of the camp were identified as women. There was an estimated 10,000 people in camp at different times. We established a location for care for women with a team of 4 midwives. I was there for about a week, and then I coordinated volunteers and funded and got people in to donate supplies and stuff like that from the time we were there in October till the camps closed months later. Some of the volunteers provided birth control, consultation, prenatal care, safe space for women during the day. And we collaborated with the medics and the birth workers in local IHS facilities. So the interesting thing about this is during the day, we provided tea and it was a safe space, but at night it was providing safe space and also recovery from people who got tear gassed or pepper sprayed. And so it was used in a very different space at nighttime. Next slide. I have to say, at the time that I chose to focus on my efforts on Standing Rock, I had little knowledge of what I need to do to set up a midwifery clinic in a conflict zone. Nobody ever anticipates having to provide this type of service or care mobilization on their own territory. Like, we talk about these things historically, but we don't really see, we've not had anything in current times happen in this way. Obviously I was deeply moved, and despite, not knowing enough about the situation and what I was getting into, I mobilized a team. So there was a lot of things that I learned from this space. One is building rapid response care systems in response to political environmental threats require an understanding of activist spaces around trust, authority, decision-making, and resources. At any given time of day, when people were out doing direct actions, the population in the camps kind of got smaller. It was mostly women and children, and then the men and whoever chose to go to the front lines who were prepared to get arrested. So that shifted if new structures needed to be built or the safety of the camp. The people were themselves resources. And so that shifted day to day. And also in regards to the kind of governance that appeared within the camps, they had their own way of making decisions. I can't say it was a democratic process, but it was definitely really challenging because you had lots of people coming to help, but there was issues with trust and decision making. And there was constant threats every day of the camps getting invaded by people and coming to arrest everyone. I feel like we got those threats a lot. Um, the other learning was that mobile clinic funding stream. So like, how do you pay for these things? The money I raised for this went to a yurt, which they had this really cool Mongolian couple of yurts come into town. They were like $6,000 each that had to be put up and paid for. People who decided to volunteer in the camps were there for months at a time and were away from work. So we had to think about maybe covering travel costs if they were going to be out of work. The other thing is food. If you're going to be in the camp and you're helping, you're also taking a food source away from others. So thinking about being self-sufficient if you're going to be in a space like that. The other thing I learned is that lot crisis ready cultural safety protocols, because there was such a mesh of different cultural perspectives and people and tribes and everybody there to help. It could have been, it was a challenge to know who you could trust, and also people's intentions. And so that can be its own little melting pot, but it's like in a crisis setting like this, how do you maintain cultural safe protocols that shifted every day depending on who was in camp? We did see a lot of transient people moving from town to town, people with disabilities who didn't get care, women who were maybe leaving an abusive relationship came and got care. So despite who we saw in camp, we saw lots of other kinds of people as well. The other thing is secondary trauma support for midwives and organizers. Like I said, the space was really nice and comfortable during the day, but at night having to take care of the frontline workers who were pepper sprayed and traumatized from their experiences of fighting, or at least their, how would I say, their peaceful protests, is enough to leave you pretty traumatized. And so it was like, how do we take care of each other? I know for myself, it took me a long time. This is probably the first time I'm talking about my experience and what I did in camp, because it was traumatizing for me too, to deal with such a volatile experience and then try to lead a team where there was challenges with leadership and decision making even amongst ourselves. And so there's that piece there. So that's something that's like, how do you maintain a space like that? In regards to policy gaps, definitely licensure barriers for midwives serving on tribal sovereign territory. So even though I was a certified nurse midwife and going to North Dakota, to the Dakotas to like provide care, like what could I do within my scope of practice? And also as a visitor on a tribal territory, what were my obligations to the tribe as a licensed professional? I would say a lot of people who volunteered obviously had different types of license and background experience, but it didn't deter anyone from going in to like provide support. But that's something to think about in regards to like when there is this type of situation happening in our territories, like if we're going as first responders, what are the challenges and the barriers to going in and helping in regards to our license and our practice. And the last learning was building rapid response care systems. So like within the camp, there were several like EMT-ish places that people could go. They had a really beautiful apothecary of herbs. They had medics who had been in conflict zones providing care. Most of them were men. And so it's like, how do you provide care in this space, but also if somebody couldn't get care there and needed to go to the IHS or get medication, like how far away was that? And is there a referral process? And those are things I had to think through quickly on where to send people if they needed it. And also, like, they did see a fair amount of women in camp who were at different stages of pregnancy, who kind of had a quick check-in with the midwives and then went on their way. There was a birth in camp, and apparently that went really well, I guess. Um, but like, it's just the myriad of people you see in these spaces. Next slide. So my next experience in regards to engaging policy and just building from the ground up is I founded Change You Initiative in 2015, obviously like a year prior to Standing Rock. And initially the goal was to create the first native-led freestanding birth center. And this goal emerged from a deep need to decolonize healthcare, return to Indigenous birth practices. Two, I recognize that the absence of Native representation in U.S. midwifery and maternal health care. Three, there wasn't a lot of community-led strategic planning processes for this to happen. And I was able to identify an Indigenous-centered process and to prioritize birthing options that were more culturally aligned. I would consider what I learned and how I did it an emergent process. So as things emerged, a fork in the road, a decision needed to be made, that changed the direction of the work. So what emerged from CWY was like a deep need to decolonize healthcare and return to Indigenous birth practices. Some of the lessons I learned is that it's really important. Healing is essential to leadership and systems change. So colonization is not just an external force that lives within individuals. Healing trauma, being self-aware is necessary for building equitable community-centered organizations. I have to say, honestly, my work in the community, I've engaged a lot of very traumatized people, not just outside patients, but within my own organization, within my own people that I've engaged with birth working spaces. And so this question of like, how do we create not just a culturally centered space, but a healing space for everyone who's going to work in that space and not just outwardly facing to patients and to clients. I also learned that decolonized systems require organizational innovation. So this design allowed to, what I mean by decolonized systems require organizational innovation. A lot of nonprofits are top down. We know that. We know that there's an ED and there's a board, and then everybody kind of filters underneath. There's a big call for changing how that leadership structure looks. But are we all prepared to engage the innovation required to develop a structure that looks different? And that also requires lots of awareness about how we feel about our own power, how we feel about communicating and working as a team. And also not letting the titles of the work that we do kind of blur the lines of why it's important that we work together. And so when I say decolonized systems requires organizational innovation, if we're going to think and dream about different systems, we have to really think about the values and the mission, but also like when you're innovating, you make mistakes. You're taking risks, you're, problem solving all the time. And so is your organization in a position to kind of go through all of those challenges and not just like set out on one path? So that was something that we learned that I've learned with Changing Initiative. Another one is redefining success. So like I said, we had initially set out to start a birth center to serve Native families. But as we went through our process, we learned that, our families still really struggled with transportation. This is New Mexico, it's where I'm from. It's a very rural area. People travel 60 minutes or longer to get through healthcare. And so did it seem reasonable to get a birth center where people still had to travel? And the model for birth center is you're there for a little bit and then you have to go home. So there isn't even a place for people to stay if they had to travel long distance in for their birth. And so there's that piece, but also when you think about benchmarks for care, they're often defined in a colonized perspective. It's all data, it's all disease process management. It doesn't always include cultural kind of like things that are important to us. Like, did this baby have their naming ceremony, or did they have a traditional birth, or did they use herbs in their pregnancy? Like, those are things that can measure like this cultural connection that our families could have in pregnancy and delivery and postpartum. But it's really important to be able to redefine our success and as to what is working for a community and not have it defined for us. Some of the things that CWI solved in regards to problems, because as I mentioned, there's lots of healthcare deserts. We shifted our focus to do care and community in relationship in partnership with the hospitals in the surrounding area, and that's a little bit more agile. There is a loss of traditional knowledge because there's oppression of Indigenous midwifery and birthing practices that have been severed through generational knowledge. This is a problem that we solved by trying to integrate traditional knowledge into our care systems, into the way we treat each other, the use of herbs, the reintegration of traditional foods. So these are some of the things that through this work that I did with Changing Women, that was one problem. As well as like food insecurity and chronic illness. We understand diabetes is an issue, obesity is an issue. We also understand like access to healthy food is a challenge. And so it's not just like a food pantry or like we're giving away free food, but it's like, do people have a real understanding of like what they're eating? And do they have access to food? And so creating this model, this bundle of care that includes providing service in your community, connecting you to knowledgeable, not just birth keepers, but traditional medicine, traditional people, access to food, and understanding what the challenges are to access food, and then also engaging the different systems that Native people have to engage just to get care. Like those are all kind of things that we figured out through Changing Them Initiative. Next slide. So as I mentioned, Native women have to engage in multiple jurisdictions to access care, right? If they're on state Medicaid and maternal health programs, they have to show proof of Medicaid eligibility or their proof of insurance. If they're non-governmental systems like urban or off reservation, there's different types of criteria they might have to show there. Tribal sovereignty, tribal authority over health services, they might have to show proof of tribal enrollment. If they're IHS and Medicaid 638, same thing. If they're getting local health provider and social services, there might be a waiver to show that their income is low enough to get those services. So you can imagine the multiple systems that Native women have to engage just to get prenatal care, to get food, to get services to help with just living their day-to-day lives. Like those are all like some awarenesses that I have with providing care in the spaces that I've provided care in. Next slide. From a legal and regulatory systems challenges, there's lots of jurisdictional fragmentation that also make it challenging for Native women to access care. Like I mentioned, there's conflicting eligibility. So women might qualify under one system for IHS, but they might be denied or delayed under state Medicaid or county services for different reasons. Underfunding of IHS and tribal health systems, that's a big issue. Trust responsibility not being enforced. So like the federal obligation to provide care is often unmet due to budget appropriations rather than guaranteed rights. So what we're seeing right now with some of the HHS reorganization and the funding shifts, like programs are not able to be fully open all the time and they're not well staffed because of the rifts. Stuff like that that affects care and access. There can also be Medicaid and complexity with state discretion. So like state to state variations, meaning state controlled eligibility, reimbursement, service coverage, even for Native women, despite federal trust obligations. This could be an issue for women who might go live on someone else's territory, which happens, right? A lot of Native women will go live in the city, or they'll move to their partner's reservation, and they have to think about what services they're eligible for depending on where they live and what state they're in. And of course, sovereignty limitations. Despite lack of tribal control over Medicaid, most tribes can't directly administer Medicaid despite their interest and capability. And lastly, there's federal law gaps and exemptions. So like the Indian Healthcare Improvement Act, though permanently authorized in 2010, remains underutilized and underfunded. So even though there's like some policy things to help us, it's not fully actuated in a way that's beneficial to us in the Native communities. Next slide. So some of the things that I recognized and found through Changing Women's Emergent Development process. Obviously, there's barriers to traditional birth choices and sovereignty. So birthing indigenous birthing practices and traditional midwifery are not supported. They're not well funded. And they're not fully protected in every state by health laws. There is no infrastructure policy supporting community-based birth centers or indigenous home birth options. Basically, funding structures, reimbursement, so they're sustainable. Native American women reported wanting home births, but the option was unavailable for financial or out of reach reasons. I hear that all the time. A lot of women reach out to me and they want to know what will cover their birth if they're choosing not to be in a hospital or to be at a birth or to be at an IHS facility. I have midwives in the home birth setting or in the birth center setting also reach out to me wondering if there's a way they can get paid or to pay to take care of a Native woman choosing to birth with them. Insufficient policy support for Indigenous midwives. There are less than 1% of midwives in the US that identify as Native American. And a lot of the reasons for that is there's a lack of systemic support financially and also places for them to go to school to become midwives. The licensing pathways for midwifery are really not designed for Indigenous models of care. And so it becomes really challenging for midwives who are interested, Indigenous midwives who are interested in becoming a midwife, to train and to find a program that aligns with their ideology as Indigenous people. And lastly, Native perspectives have been historically excluded from health policy making and clinical leadership. So Changing Women is really pushing for structural inclusion and self-determination in care delivery. And we've done that on different settings in the UN setting and then also on the state setting and now the national setting. Next slide. So some of the work that I've done on the human rights and legal advocacy side, in 2019, I contributed to the development of a federal briefing on Indigenous maternal health issues for members of the US Congress and their staff. This led to human rights fact-finding effort conducted by the Center for Reproductive Rights, documenting Native women's concerns about the lack of available, accessible, quality maternal health care in general. This letter led to contributing to a shadow report submitted by the U.S. Civil Societies Organization to the Committee on Elimination of Racial Discrimination, or CERD, in preparation for the 10th review of the U.S. At the time, I traveled to Geneva with several Black and Indigenous reproductive justice advocates to deliver an intervention during the UN session on information about sexual reproductive health rights of Indigenous women. There were some really cool things that came out of those things in regards to language and also holding our country accountable to how Native women are treated in childbirth and the lack of access we have to our traditional midwives. This report is groundbreaking and was published. It's part of, the larger picture. So you're seeing me move from front lines, providing emergent necessary care at Standing Rock, to establishing a nonprofit to provide maternal health care, and now moving into the global and national platforms to address improved policy, reform policy, and access to care for Native Indigenous people. Next slide. This particular one I'm really excited about. So last year, well, maybe 2 years ago, it feels like last year, I serve as an expert witness in a lawsuit filed by the Center for Reproductive Rights on behalf of Native Hawaiian midwives and others. This lawsuit is where Hawaii was challenged by my friend and a couple of other individuals about some licensure that was being implemented that would criminalize and exclude their community's access to traditional midwifery. And so I provided testimony in regards to the impact of colonization of maternal health for Indigenous people. After a week-long hearing, the judge found the law's restrictions on Native Hawaiian culture practices to be unconstitutional and blocked the part of the law. And in 2025, and was able to, this last year, they were able to pass different legislation that supported Native rights. This is groundbreaking because this is the first time that traditional midwives have sued the state and have basically tested the right to practice in their own territory. It's a big deal. It's never happened before. And so the only reason that was able to happen is they were within the Hawaiian Constitution. It protects traditional Hawaiian medicine, in which traditional midwifery falls under that category. And so this to me is like, these midwives tried every avenue possible to get their legislators to hear them. Times that I've been out to Hawaii, these women slept on a sidewalk when the law was getting passed, and their legislators wouldn't even hear them. And so they were kind of forced into a position to sue the state for their right to be in their community, and they won that right. And so I would consider this, like I said, groundbreaking and something people need to be aware of. It's a big deal. Next slide. So all of those experiences have led me here to Washington, D.C. I'm really proud to be a Robert Wood Johnson Health Policy Fellow. As I mentioned, I work here in the Senator Ben Ray Lujan's office for New Mexico. It's been a crazy year. You guys all know. We didn't know what kind of crazy year we were going to have. As of right now, there are over 100 executive orders, over 21,000 involuntary separations of federal employees so far in 2025. This is the largest health and human service reorganization happening, which has resulted in 10,000 workforce cut. Under the Administration for Healthy America, or AHA, they're merging functions of HRSA, SAMHSA, and some other really important HHS programs. Some of the programs that have ended are like the Pregnancy Risk Assessment Monitoring System, the Environmental Public Health Tracking Program, the HIV Prevention and Surveillance Program. And so this has also greatly impacted tribes. According to the National Indian Health Board report, more than 6 million tribal-serving HHS grants have been canceled, and key programs have been eliminated in the CDC. One in particular is Healthy Tribes, Center for Indigenous Innovation and Health Equity. There are regional office closures, so there's less hands-on help. There are 5 HHS regional offices: Boston, New York, Chicago, San Francisco, Seattle. They're closed, so they're reducing on-the-ground technical assistance for tribal TANF, Head Start, IVB, child welfare, etc. And then more importantly, CDC and data surveillance disruptions. So tribal advocates point to removal of CDC public data and halted programs, which have undermined tribal data sovereignty and tech-funded work. For example, Good Health and Wellness in Indian Country and Tribal Practices for Wellness. So my time here has been really important because the 2 portfolios that I get to participate on is tribal affairs and health. And some of the things that I've been able to do this year, and one in particular that I'm proud of, is that I was able to kind of ring the alarm in the office when one of the EOs was to basically get rid of 850 IHS healthcare provider jobs. And we were able to rally with external organizations to save those jobs, in which we did. By end of day, that HHS Kennedy kept those jobs. Some of the bills that I've been able to reintroduce is the Midwife for Moms Act, the Tech to Save Moms Act, the Babies Act. These provide funding for midwives, funding for birth centers, and more importantly, the Indian Program Advance Appropriations Act. So like right now in this shutdown, we know like there's tribal health programs that are not funded or are not being funded because of the shutdown. I would say more than half of Indian country is federally funded. And so when there's a shutdown and there's not prior approval for that money to go into the next year, it stops. Like we're seeing that right now with SNAP, we're seeing that right now with Head Start. I hear from multiple tribes how they're being impacted by the shutdown, but also by the EOs and some of these things that have happened in the last 6 months. So thinking about my body of work, right? Like all of these experiences that I've had on the community side, being with people, fighting back, and then now being here in DC, being able to kind of witness and participate and to, how would I stop some of the harm that's happening by engaging tribes and understanding how they communicate their needs and engage government so that their needs get met. Those are some of the most important things that I'm learning so far. Next slide. One thing that I'm working on right now, which I'm really proud of, is a couple of months ago, I had a conversation with Senator Lujan about needing to improve American Indian, Alaska Native, and Native Hawaiian maternal health. Something I've observed is the Black maternal health movement has gotten a lot of attention. It's gotten a lot of support. It's got a lot of funding. There's a momdibus that still hasn't been reintroduced in this legislative session. If you go to the Black Mama Caucus, was it Black Mom Caucus? Yeah. You will see how much money they've garnered through the appropriations process to improve maternal health. Ideally, yes for all, but nobody's really championing maternal health on Congress for Native people or in Congress for Native people. We could definitely create policy and legislation and take a stab at what we think, what's happening and what is needed, but that's not really making good policy. And so right now, through the summer, my office and through my time here, I've led 5 reports to basically give some background and some policy recommendations to improve maternal health, specifically in these areas. So like data sovereignty, maternal health care access, what our workforce looks at, maternal mortality, maternal health care access. And then the last one I think is really important is funding. And so the funding is basically looking at like how much investment has there been on the federal side, on the state side, and then through philanthropy to actually address and improve maternal health for Native people. Those reports are finally wrapped up. I've gotten all the reports in, and I'm hoping once the shutdown's over that we can release those reports and do a press and a briefing on what the findings were. I've read through them all. They're pretty impressive. I would say it highlights some of the real challenges of what we're all seeing in our community, and it creates a story and a narrative and a body of evidence about why we need to change policy, why we need to fund maternal health, why we need to fund our healthcare workforce, why we need to protect our data and create policies between tribes and between government on safe practices that support our self-determination and our sovereignty. And so being able to create an impactful report like that while my here in Congress has been probably the most important thing that I feel like I've done here, and is a culmination of all the work that I've done like through my life, because it creates a frame and a history and a grounding base so that whatever follows, that there can be a follow-up to see what policies have been implemented in the next 10 years after this report. Next slide. So some of the really key findings from the report is huge, right? Less than 1% of maternal health research funding is allocated to Indigenous-led programs. Surprise, right? We're not putting enough money in our Indigenous-led programs. Two, maternal mortality and perinatal mental care. So suicide and overdose accounts for 23% of maternal deaths, yet only 15% of prenatal providers report training on culturally responsive care for Indigenous populations. So if, you know, a lot of our women die from suicide, overdose, and mental illness, and yet very few people are trained to take care of us, like how are we gonna address the problem? The last one, obviously, we all feel this: fragmented systems of care between federal, state, tribal, local health programs. They operate in silos with limited coordination, resulting in service gaps and confusion happening right now. And last, policy gaps. As of 2022, only 3 states had formal data sharing agreements with tribes, which contributes to policy gaps, misaligned funding, and continued invisibility of maternal health disparities. Another finding, and this is a post I actually put on my social media, was that rural regions are home to 40% of Indigenous people. But it was reported that 25% of American Indian Alaska Native births took place in maternity care deserts, basically counties without obstetric facilities or providers. So I imagine these women birthed in an ER, or they birthed in a bathroom, or they birthed on the side of the road or a parking lot. 25%. To me, that's a failure of our system, and that's a failure to our moms and babies. Next slide. So I'm really happy to share this slide. I know Misty worked in this working group to get some of this information. A lot of the challenges that some of the innovative maternal health models have is building a workforce to serve Native communities. We all want our own Native providers. But there's so little Native representation in each sector of workforce. So like specially registered nurses, only 0.8% of the 4.7 million nurses identify as American Indian, Native Alaskan, Native Hawaiian. That's 37,600. Same goes for OB physicians. Only out of the 19,820 OB physicians, only 59 of those identified as American Indian and Native Alaskan. Certified nurse midwives, same. There are 14,250 certified nurse midwives in our country, and only 100 identified as American Indian, Native Alaskan, Native Hawaiian. I think we're seeing really also a huge detriment in our advanced practice nursing section. There's 500,000 APRNs in the US, and 0.3% or 1,500 identified as American Indian and Native Alaskan. And there is an absence of American Indian representation in clinical nurse specialist roles, certified registered nurse anesthetist roles. And so there's a real challenge here as to like, how do we get more Native representation in our health care programs? This was part of the report that was submitted, and I just pulled it for today because I felt like I'm talking to you all. You guys need to know like what that looks like in real numbers today. Next slide. So these are some of the policy change levers I engaged in my career. One, Changing Woman provided proof of concept that policymakers can visualize and fund and expose policy gaps to support innovative community-led work. Two, I participated in the United Nations and global human rights work. So as an international accountability mechanism, that general authoritative recommendations that advocates to re-import into US legislation and court briefs. The case in Hawaii tied domestic law to human rights standards used in court victory to set precedent and influence state legislators around traditional midwifery practice. My time here as a health policy fellow has placed me right in the epicenter of policy change, but I was able to bring my community into this space to create reports and inform policy in a way that it should be, so that there's good policies still going to be moving forward. And lastly, in all of the spaces that I've been in, it creates an opportunity to create cross-sector convening. So working with tribal leaders, federal agencies, maternal health coalitions, frontline workers, frontline coalition builders. I've engaged all of these areas within policy within my time to make the changes that I've been trying to make to improve maternal health for Native people. Next slide. So why these levers work? CWI provides real world practice evidence, right? It's established, it's doing the work, it's evidence. The UN model allows for outside pressure to set normative standards and legal precedent, which US needs to be held accountable for that. The fellowship provides inside track to translate into legislative innovation with policy recommendations from community into these policy spaces. And then lastly, the expert testimony and the judicial precedent protects Native Hawaiian practitioners and sets precedents for other states, right? This is going to have continued effect in other states and not just in Hawaii. Last slide. So I want to iterate, like, I hope the takeaway from me talking about all of these things is that by bringing together grassroots knowledge and SADR policy experience, legal action, narrative power through my midwifery experience informed policy lens, a multi-layered change engine is created, right? I engage multiple systems. I just didn't do it one way every time. And each lever reinforces the other and leads to legal binding change. Next slide. So I just really appreciate all of you for being here and listening. I'm really curious if you guys have questions for me. I know I went hard into policy, but I wanted you to see the natural progression from like front lines to state to federal to national to global, and all the ways that we can engage policy for the better for our community. So thank you for giving me an hour to talk about my experience, my knowledge, my wisdom, and I'm really welcome questions from anyone at this time.
Thank you so much, Nicolle. If folks have questions, you can either put them in the Q&A, or if you're able to unmute, I welcome you to ask as well. And maybe while we wait for that, I'll ask a question. So you know the work that I do with Pathway, but I also have previous work with increasing the diversity of our nursing workforce and getting more American Indian Alaska Natives into nursing. I'm curious what advice you would give those who are considering nursing, and how you might help them to get where you are today. Because I imagine you didn't think you would be where you are today when you started out your nursing career. So what kind of advice would you give to those considering nursing or new nurses?
Yeah, I think nursing provides a really good base to begin from because you can do so much with your nursing degree, right? You have hospital nurses, floor nurses, you have nurses who work in a home setting, in a school setting, in a university setting. Like it's such a diversified role to have. And you'll always have it, right? I've been a nurse for, I think, 20 years now. It's been a long time. And I'm proud to say that I'm a nurse, right? And I meet with nurses all the time here in the Senate, on Capitol Hill. I think because nursing is its own front line and you get to experience and witness that one-to-one and that relationship with your patients and with your clients. But sometimes that really that can build something in you, right? You recognize some of the disparities and equality working as a nurse. Like, you recognize that the staffing ratio to taking care of patients safely is not always the best. You might recognize that as a nurse, sometimes you don't feel heard and you don't feel like you matter in a larger hospital system because you're a nurse. Even though the outward messaging is like nurses matter and we trust them, they're most trusted healthcare professional in the whole United States, even over physicians. And so if they're starting to notice these inequalities, like there can begin to have a feeling like, I want to do something more. And how do I build on this body of knowledge that I already have? My process for getting where I'm at really stemmed from what I witnessed in my community, as a nurse working at IHS at my first job, and like the long johns I had to wear under my scrubs. And I was really appalled by how women were treated. I was appalled by how I was treated. And I was like, man, I just had 5 years of excellent education and this is where I'm working and this is how I'm getting treated. Like, this is not okay. And so that really pushed me to get my nurse midwifery. And then I saw challenges there too. And so like at every avenue of education I pursued and every space that I worked in, it was like a real visible disparity and equality always when it came to being a Native woman, a Native person. And it's like, there was just this weird feeling of like, well, this is always how it is, so just be okay with it. And I'm just one of those people who I'm not okay with the way things are. I think about being complicit to issues and not speaking up kind of keeps us where we're at. And I didn't go to school to be okay with the way things are at. And so I think anybody who's choosing nursing as a career, they might find themselves in that position where they want to do more with it and they can do whatever they want. I mean, I don't have a PhD and I've definitely gone back and forth with it. But I've realized that I have enough experience that that's not what I need right now. Um, and that the life experience that I have is more valuable and I can do more than spending 5 years in a program. But that's for me. That could be somebody else could choose that path. I don't, yeah.
Thank you for
Oh,
that.
let's say Monica has a
Yes,
question.
Monica, if you want to unmute and ask your question.
Sure. So excuse me. Are you guys able to hear me?
Yeah, we can hear
Yes.
you.
Okay. Um, so I'm a master's in student at the University of St. Thomas, and one of the things I love about our program is they very much so focus on the cultural competencies and whole person well-being. I have an undergrad in social work and got a lot of that cultural competency training there as well, and have worked as a paramedic for in North Minneapolis for the last 5 years, and have seen some of those disparities where you see, women who are Indigenous or otherwise delivering babies in someone's basement on the side of the road in the back of an ambulance. And as a provider who's really passionate about women's health and L&D, OB, all of that, and as a white provider, I guess my training in cultural competency prior to all this still in many ways makes me feel unequipped to truly like boost the voices and the experiences of fellow providers and patients who are in these other populations. And I guess I'm curious what maybe suggestions or experience you have in, I mean, I acknowledge that as a white provider, even as a woman, I'll oftentimes we're maybe listened to a little bit more. And so how to use these experiences and things to really boost those voices of like colleagues and patients to make sure that these issues don't kind of fall back. Because I do think policy is a huge thing and wanting to be involved in that, but not exactly sure how to utilize it to the best of its ability.
Well, I think that's a good question, and I don't know if I have a good answer for you, to be honest. I think I get actually this question a lot in a lot of different ways of like, how do I as a white provider support Native-led policy or Native communities or Native, spaces within the space that I work in. And I think that's a really challenging place to be because one, you have to acknowledge the harm that's been done and be vocal about that. Like our history is not really pretty. And also our current narrative is not pretty either. And so acknowledging that in all the spaces that you're in is very helpful for us. Two, I think individually out and not as a whole collective sometimes. So I think about that internal work around your own biases, and your perspectives and how that mirrors out into all your relationships and the work you do, like spending time with yourself on what that looks like. I think it's a really hard question to ask of like, what is my role as a white person in this work? I don't know if I have an answer for you. I feel like that's such an individual question, that I feel like I've had that people have asked me and I'm like, I don't really ever know how to answer that question.
Thank you. I appreciate it. And I think hearing the perspective of the acknowledging of like an internal bias and really spending time with ourselves to acknowledge those things is, I think, something people don't think about, even myself. And so hearing that from you feels like a really good answer. So I appreciate that and hope you continue to share that with other people who ask that same question.
Yeah, something also interesting has happened with me here being on Capitol Hill. Like I'm the only Native person in my office. I'm like the fifth Native person on Capitol Hill and all of the Senate and House representative offices. And so when there's debates about policy and there's discussions about communities that are mine, which is like I identify as I'm a Native person and I'm a tribal enrolled member, like I have to listen to people who don't understand our communities debate his policy and not think about the impact sometimes. And also understand that there are multiple issues going on at the same time. And like our issues as Native peoples compared to the country are very, very small. And it's surprising when I've had these harder discussions with my colleagues, especially when it came to Medicaid reform and the positions that the Dems were taking in regards to how they've viewed our political status versus us being a specialty group. Like I was just appalled. I was like, what do you mean that you think we're a specialty group? We have Native status, like it's the law. You have to follow the law. You have to give us special recommendations, special circumstances to meet our healthcare needs. It's not an option, right? But it was being discussed as an option. And so there's a lot of spaces that I'm in where I don't always agree with the conversation that's happening, but I'm also getting a perspective of like where we fit into the bigger picture. And most importantly, watching how the tribes build and maintain relationships with their senators and their House representatives when it comes to specific issues of their tribes. Like it's really powerful to see because how do people who don't have political power get their needs met? Like really that's a study, a path of study that I'm on. And I'm finding that relationships are really important to maintain with not just your government, but with each other, with your community. And that can be really challenging because people can be harmful to each other. And I've definitely experienced that in a community setting. But I wonder sometimes if I could go back and change even how I've navigated spaces now that I understand the importance and value of relationships, why it's important that we work together, that the communication's open, but also that we don't always go on the attack. Like I think sometimes in community, we've been harmed so much that we have a trauma lens of like, we don't even think about like, why don't we just go have coffee with them and ask them what's going on versus like, we're gonna send a letter or we're gonna shame them on social media. What I see playing out in the Senate side of things when I engage with the House Secretary Kennedy, when I engage with other senators, when I engage with other senators' staff, it's an email, it's a check-in, it's a coffee, there's mutual agreement, there's also mutual disagreement, but it's not a huge fight. And I'm like, oh, well, if we can have some agreement amongst ourselves on how we're gonna move together, like, why are we not using these levers for change in our community? And I get when things are not working, we're forced to, you know, to make a stand and to make a more like, to sleep on the sidewalk, like those midwives did in Hawaii, and they were forced to sue the state. But that doesn't have to be the case every time if we can have good relationship with each other and like build off of those relationships. And that's something that I'm taking away from this experience, and something I've taken away from every experience I've had, is the different ways that we've all engaged across sectors to get our needs met. And sometimes it's very loud, and sometimes it's just a conversation over coffee. But that's the places that change is happening. I think we could all be better at that.
I think those are really great words to end the presentation on. Thank you so much, Nicolle, for sharing your powerful journey and inspiring future generations, and your commitment and advocacy to Indigenous communities. Thank you so much. And thank you everyone for joining us today.
Yeah, thank you. Thank you for being here.